This is the first hybrid seminar of the Global Health Unpacked seminar series that we've had since launching the series with the Center for Global Health here at the University of Oslo in 2017. We've been resisting because we wanted to make this a space for a very open and intimate conversation. So we still encourage those of you in Oslo to come in person, but are very happy to open this up to others around the world who are interested in exploring the politics of global health from a critical social scientific perspective. Today, we are very delighted to welcome Dr. Rachel Chapman, who is visiting us here at the University of Oslo for the month from the University of Washington. It's been a real pleasure to exchange with her over the past few weeks, and we're really happy that she will be giving today's seminar. Rachel Chapman is an anthropologist and works on gender, race, reproductive health, and social justice, focusing on the urban United States and southern and eastern Africa, particularly Mozambique, which she has just recently been visiting. So today she's going to talk about a fascinating project she's conducting in Seattle in the United States in this seminar, which is titled Good Black Birth, Reckoning with Maternal Health Disparities Through Black Authoritative Knowledge. So before I invite Rachel to take the floor, I just want to flag that we'll have some time for a discussion, a Q&A after her presentation. So for those of you online, you can write down your questions in the Q&A box on Zoom, and I'll try to bring them up as we move to the Q&A. Or you could also raise your digital hand, and then I will invite you to ask your question on camera and voice so that we can have a more face-to-face discussion. With this, I would like to introduce Rachel, who I think is now ready to give her presentation. I'm going to hand over to you.
Yeah. It's not right. I fixed it.
Okay, just 1 second.
Good afternoon. I know that this is not a large group of anthropologists, so I want to introduce myself. I am a professor of medical anthropology at the University of Washington in Seattle. And I want to describe an anthropologist as someone whose main work is listening to and transcribing the symphony of life. That's a poetic way of talking about it. But we've also been called, particularly by Paul Farmer, the most radically contextualizing of all the social sciences. And when James and I were in graduate school, we were taught that the gold standard should be finding the articulation between the micro and the macro. And that continues to be somewhat of a gold standard that we talk about with our own students. And that articulation, being able to tell a vivid story about what we find at the nexus of the micro and macro, and putting that in historical time in terms of human lives and the worlds we inhabit, the worlds we dream of, create and destroy, that is the best definition that I could give you in a short time of this field. And today I want to tell you a story, do some storytelling about some work that James Pfeiffer, who was here and gave a talk a while back, and I've been doing with a big team, with a big team in Seattle in the US, where, much to your surprise, we have not had a racial reckoning. And I wanted to start the talk not only by defining anthropology, but reckoning. And by reckoning, I don't mean big feelings that were had by people who were brought up to think of themselves as white, about things they profess they cannot believe happens to the rest of us, as a functioning part of late racial Hispano capitalism everywhere. So it is not about guilt and grief. It is about it's about something that the emphasis not on remorse, but on fundamental change, and especially the expectation, nothing less than a dramatic transformation and improvement in the lives of ordinary people of color. So we might ask, 4 years after the murder of George Floyd and all the racial uprisings that were in the United States, can we honestly say that there has been significant transformation in the lives of everyday people? And the answer is no. Police killings of Black, Indigenous, and other people of color in the United States, poor and especially people with untreated mental illness, has increased since that time in 2020. And in our prison industrial complex, more Black people are incarcerated now than were enslaved at the height of the transatlantic slave trade. About 13% of the population in the US are of African descent, but 30% of those who are arrested, 35% of those that are in prison, 42% of those that are on death row, and 56% of those serving life sentences. And this is predominantly men, but increasingly women and children. So given this backdrop to this story about work that we're doing in Seattle, I also want to tell you I'm an anthropologist and an abolitionist. And to define abolition, I want to paraphrase activist and author Miriam Kaba, who beautifully defines abolition in her wonderful book, 2021, We Do This Till We Free Ourselves. And that definition is, abolition is rooted in imagination and experimentation. It's transforming our imaginations to envision and build a way out of oppressive systems. Abolition work is to create the conditions for dismantling prisons, police, and surveillance through 1,000 new experiments in liberation and care, experiments that learn from the past failures and chart new terrains of freedom. So for those of you that aren't familiar with what that means in terms of abolition, it's not about police reform. The problem of policing, and this also comes from Miriam Kaba, the problem of policing is not lack of trust or relationship between the police and the police. The problem of policing is that police's basic job description is to uphold anti-Blackness by managing inequality and suppressing dissent. So we could say that our prison industrial complex is not broken in the United States. When the prison industrial complex causes death and destruction, it is working at peak efficiency. Calling the PIC broken reaffirms the misguided possibility of reform and acts as a counterinsurgent force against abolition. So we always talk about police, they're always undergoing some sort of reform, yet police violence has never stopped because violence is inherent to rather than an unfortunate byproduct of policing. So abolitionists give up on reform to a certain extent. And violence is the place and time, this place and time is also a byproduct of our healthcare system. So that is a backdrop to beginning this story. Here's a brief outline of what I want to do, but these two slides sort of begin to talk about that backdrop. And that we've not had a reckoning. And everything that we've done has played out against this backdrop. So it's not a surprise that there's an urgency to Black maternal mortality, given what I've just talked to you about. Black maternal mortality could be seen as a canary in the mine shaft for whatever cruelty, violence, and disenfranchisement is happening in the US as a whole. And this cruelty, violence, and disenfranchisement is also transracial. As you can see, all women in the US are faring worse than their counterparts in other wealthy countries. And this is especially powerful to consider from the vantage point of being here in Norway, the best place to reproduce, it would seem. What can the rest of the population expect? We know the reasons why this happens in Norway. There's universal healthcare, lots of midwives, 54 per 1,000 live births to 4 per 1,000 live births in the US. Quality postpartum and paid leave, which I'm hearing about from everyone around me. Oh, and I just wanted to mention, there is some data that troubles this zero. Some work that was recently done in Norway on undocumented and documented migrants shows that 6 times, undocumented migrants have 6 times the risk of perinatal, that is for fetal or neonatal death, than non-migrants. and undocumented migrants have 4 times the risk compared to documented migrants. So there's something else in that zero that needs to be unpacked. We also have some really good ideas about what is behind these disparities, and they're not surprising. Structural racism in healthcare, implicit or explicit bias in people providing care, lack of access to good reproductive health care, and economic determinants like poverty, housing, and unequal education contribute. And this has been in the headlines. We know that even the rich and powerful are not spared from this outcome. These are just some of the recent headlines from Serena Williams to Tori Bowles, who was an Olympic track star who died in childbirth. We know what's behind the crisis, but if it is American heritage to break the Black body, and as anthropologist Zora Neale Hurston said, the Black woman is the mule of the world, it's not surprising that there are these headlines. Wealthy and famous are barely making it or not making it at all. So what can the rest of us expect? This is beyond wealth and power. We know a lot about the gaps and in the current policies, and we've talked about them. In many ways, it's stark contrast to Norway, from inadequate governmental subsidized care, standardization in practices, data collection and spotty, and very importantly, increasingly, a large amount of maternal health problems come from untreated mental health during and after pregnancy. And we know, as I said before, there's a deep undersupply of maternity providers and not OBGYN so much as midwives. We also actually know a lot about what policies make a difference, and it's been shown all over Norway. And we need to expand Medicaid. We need to incorporate community-based doulas and midwives, as at least Sweden is doing very intensely, and we know some of that happens here. These are 3 examples. The California Maternal Quality Care Collaborative says that just having data on what's happening and having some specific quality improvement kits has made a huge difference, declining maternal mortality by 65% since the beginning of this project in the state of California. In Washington, we have now advocated for doulas to be covered for all people receiving Medicaid. It's at a very low rate. And the Florida Common Sense Consensus is based on a European model, and we know that that works. So I want to go through and just tell you quickly some of the projects that we're working on, and there are 4 that we've been working on. Sorry, it's a bit sticky. Birthing Diversity, Mama Aman, Healing Heart and Soul, and then Heart, Soul, and Joy is the 4th project. And I'm going to go through these really quickly, and you can ask me lots of questions about them, but I want to get to some central paradoxes that have come out as we're finishing up this last 4th project over the last 7 years. So Birthing Diversity was very traditional anthropological ethnography, listening for a year to communities, especially in Seattle, very underserved East African refugee and immigrant community, and just listening to where the gaps were, what people wanted, what they missed, what they didn't know about, what they envisioned. And very rarely you get this funded. We actually got funding to put in the service the thing that people had said, this would be great. So we had pop-up peer-to-peer perinatal education with culturally embedded community members delivering care and education. We had doula care that was free for everyone, and monthly classes going through a really importantly Muslim and East African culturally appropriate set of modules. And it was going great until we were interrupted by COVID-19 quarantine, which in 2022 shut down all perinatal care unless it was urgent or it was 1 week before or after birth, which distanced a lot of people from care. We were already talking to people that were significantly underserved, and we're like, how do we not leave these communities and also leave them at risk? We knew that preeclampsia and eclampsia, hypertensive issues during pregnancy, domestic violence because people were losing jobs and income and housing. We knew that stress and depression would be going up for people that were also trying to balance making new families and becoming often new parents or parents of another small kid. So we came up quickly with something that was called a COVID Rapid Impact Grant, which we called Healing Heart and Soul. And it was very, very simple. We said people aren't going to get to see their physicians and their midwives. They are going to have the potential of having high blood pressure and not knowing about it. So we made sure in 6 clinics where we worked that there were everyone who wanted to had a free blood pressure cuff and a screening tool to bundle measuring these biological input that everyone agreed was important: heart rate, blood pressure, and stress for screening for stress, depression, and for housing insecurity and relationship violence risk. So very quickly, here's some of our methods. We were basically doing a pre and post to see how people thought of this. There's a feasibility to see if providers liked it, if it helped with communication. We ended up having 117 people and 18 providers, and everyone got this training and this kit. It's important for the rest of what I'm going to say to know that 70% of the participants and the people seeking care at these community clinics were African descent. And people self-identify. We just wanted you to see how people identify themselves. And 100% of white providers in these clinics, which is really usual in the United States, that the doctors who will take less pay are sort of well-meaning, good doers who are willing to work in these community federally funded and grant funded clinics. This tells you a little bit of the story about developing the tool that we used that people could look at. We were dealing with many, many languages, more than 25 languages, but we couldn't translate it at all. So we were using color and image for people to be able to talk with their provider. And if they were in the green zone, they're doing fine. If they're yellow, they should call. You can see that directive. And if you measure in the red zone for any of these things, call your clinic, but pack your bag and get ready to go because you're probably going to have to rush to care. So yeah, we did that. And we found that people liked it. Providers and patients said, wow, we're having conversations we've never had before. People are calling, in fact, some of the nurses were upset. They felt like people were overutilizing care, but we were saying these are people who don't get any care and they actually have the confidence to call you and say, I need care. I know something's wrong. I need care. And what we gathered from that is that we can do this. This is possible. This should be funded. It increased communication as we thought, and it increased patients' involvement with their own care. And at the end of this, we gave it a name and we called it Black Authoritative Knowledge because it was mostly women of African descent, that if you felt this increased confidence to monitor your own bodily, mental, emotional, relationship health at home, people talked a lot about awareness and embodied knowledge and control and peace, which led to agency, which led to autonomy and self-care, which led to self-advocacy of people reaching out and using knowledge and data to say, no, I need care, which we said it's a good hypothesis that if you have increased service use outside of regularly scheduled phone calls, you might get better outcomes. So I have to give credit where credit is due, that Brigitte Jordan is an anthropologist who came up with the term authoritative knowledge. And she was looking at the most well-resourced white women in California and looking at how even they were in biomedical clinics, really decentered, with the obstetrician having all the knowledge and all the power to make decisions, and really looking at how people got decentered and disempowered in this And we thought it was a great term, but we wanted to kind of take it and shake it a bit. So what is Black authoritative knowledge? And I'm going to read these. It is rooted in Black embodied and ancestral wisdom. It promotes autonomy and self-efficacy, powering oneself to make decisions. Mitigate, resist, and undo comes from public health scholar Arlene Geronimus. And as a way of talking about how harm needs to first be mitigated before it can be resisted and then its trauma is undone. Centering Black people's experience, which doesn't happen. And we wanted to say, rather than something that needed to be seeded by powerful care providers like OBGYNs to nurses, midwives, and birth givers, it's actually inherent within people, and you need the conditions in which it can be expressed. So we saw it as something that in and of itself, the awareness of which could inspire, shift, to reimagine and transform processes, protocols, spaces, lives, futures. So our fourth project is called then Healing Heart, Soul, and Joy. And I should add that Black authoritative knowledge really started as a shift in our research methodology. This is a team of more than 10 African American and African researchers, community caregivers, who are all working on this project. And we realized that our own pathologization of Black birth and Black families and Black women was making us sick. So we're feeling like, whoa, this information, we have to change something. So moving beyond seeing ourselves and our people as risks and as harm to ourselves, we said, we've got to talk about joy. We need to change how we do research, and maybe that will change how we deal with the people around us and how actually we might envision care. So we had this saying, let joy lead, which is why I started asking you, what brought you joy today? And we wondered if this commitment to centering joy could make a difference in practice as well as in research methodology. So that's all backdrop to get you to this other important, tiny, hidden finding that we have. Anthropologists are obsessed with paradoxes. Wherever you find two things that kind of challenge each other, you know there's something hot, decaying, disrupting, some friction within cultural settings. And it says, look here, stay here, listen. So there were two that we wanted to pay attention to. And the first was that all these folks that we were talking about who were pregnant or just given birth, were talking about during COVID, anxiety and power happening at the same time in relationship to healthcare. We're totally stressed out that we don't have healthcare, but we're totally confident. That felt like a paradox to unpack. The other paradox is that we knew epidemiologically the data was coming in that maternal and infant outcomes were worse for everyone across the board during COVID. But we had case studies within our group that this quarantine had created a kind of shadow that heightened risk for some people and protection for other people. Right. There were contrasting births that happened that we had started to get some real descriptions of, and we wanted to look within that shadow. So there was a bad birth. This is kind of putting all of these together, but it was characterized by everyone being seen as at risk. You're pregnant during COVID, you're at risk. People getting inadequate prenatal care because they've shut it down, except by telephone. You're not allowed to bring your family and social support in with you when you go in for labor. Black people, women, and birthing folks were getting extra pathologized because Black people were dying of COVID more because of institutional racism, but then we were seen as both as a danger to ourselves and to others. Like, what's the relationship between Blackness and dying of COVID? So people were really feeling that. So this isolation that happened during labor and delivery and after in understaffed, overburdened, and also very uninformed birthing units was a trifecta for them at birth. So that's really kind of putting everything together that we heard. In contrast, at the same time, people had these good births. which centered what I just talked about as Black authoritative knowledge, fostered Black family support, and especially Black authoritative knowledge to decide the flow of birth. Who gets to decide? Who has somatic knowing and tradition to sort of oversee what's happening? And it safeguards Black people, families, and in that way, communities, and the sense of being agency, full of agency and autonomy and self-efficacy to life give and life save and advocate self-care. So I come back to mitigating, resisting, and undoing trauma. People talked about healing. This was healing to have this happen. And people thought, I'm never going back to this other system that is so hurtful to me, to my body, to my psyche. And more than reproduction, it promoted healing and joy in Black play, in Black sexuality, in pregnancy, in birthing, and futures, which sort of also unpacks a deep stereotype about Black women as being reproducers, people with futures and community futures. So a very, very preliminary Black authoritative knowledge birthing framework insists for us that it has to be more. It seemed that access and incorporating education and support into the existing model is not to be enough. And that we had to consider that there is potentially a pathogen that in a eugenicist society, healthcare itself is a pathogen, virally so to Black parents, infants, and families, and that the good birth, however rare it was, however you could grow it, repeat it, replicate it, support it, that was a form of resistance, of reproductive refusal to give your body to a very controlling set of techniques, protocols, with what seemed to be predictably often negative outcomes. And we talked about this as microvisionary and viral. It's not a grand, this is going to save the world, but birth by birth by birth, there's this incremental, contagious, interdependent approach to change through daily small acts that we wanted to uplift. And that comes from Ruha Benjamin's book, Viral Justice. So there's some very obvious policy recommendations of expanding Medicaid postpartum to up to at least a year and include these things that we saw people really appreciated and needed, from blood pressure cuffs to domestic violence support. Funding more data to be collected, and fully funding community design-led and based projects that included midwives and doulas, both pre and postpartum, which seemed really attractive, especially to women born outside of the US who didn't want a stranger at their birth. They had family, kin, sister, mother, but that they really wanted help after birth, which is traditional in many countries for 40 days. And we based that on the Somali practice, of 40 days of being cared for by your family, holding your infant, braiding your hair, massaging your body, washing you with salt water, taking care, making sure that you're okay. So, yeah, policy recommendations. These seem basic, but listening to Black women, cultivating racial justice, not just in healthcare, but in all sectors of life, because anti-Blackness is a global phenomenon. And having been here in Norway, where I go in between thinking I'm in paradise to wondering why aren't people talking about this, would it mean to face and resist racist, anti-immigrant, and Islamophobic divide and conquer tactics? Maybe more obvious in the United States, these agendas that are really a veil to destroy the commons, to cut public social safety nets, to crush workers, to protect private greed. But James and I heard from one of your countrymen, and whether he is an odd, off the grid anomaly, his exact words were, I'm sick of paying taxes. The Somali mom with 7 kids is a leech to our system. Point, stop. So he'd already constructed the other. He'd already said exactly what the problem was about reproduction, was about Black reproduction. He acknowledged that Norwegians also were leeches on the system. He acknowledged that he homeschooled his child because of your crazy public schooling. But just really paying attention, facing how this is bubbling under the surface and how discontent can become racialized and how that might become unacknowledged policy that slips into the way in which people treat each other. There's always a role in community, which is why we start with community-based support. We've known this for 30 years. In all the places we've worked, almost nothing works without community centrally involved in directing it. But we know a lot about that. But I wanted to ask you a question, even though Norway has such a stellar health maternity care system and policies, how and if so, why are any of these dynamics at work here? Norway, Oslo, Sum. I study maternal health because it is a pulse to any community. You tell me how your mothers are doing, I'll tell you how your community is doing. And I think that Black authoritative knowledge is relevant to all institutions that make decisions. So I open it up to you for questions, comments. That is, in a nutshell, 7 years of work and some of the things that we're thinking about. Yeah.